Hello and Happy New Year. This is Dr. Bernstein with the first edition of Dr. Bernstein's Diabetes University in the year 2023. We begin with the usual caveats, namely that the answers I give to your questions are generic answers that may not strictly apply to your question, but will be educational for the listeners, which is the main purpose for this video. So consult your physician before changing any medications or making major changes in your regimen. To submit questions for Diabetes University, you dial into diabetesuniversityquestions@gmail.com. diabetesuniversityquestions@gmail.com. That's where you submit your questions. If you want to know when the next video will be presented, you have to periodically go to YouTube, where you look for Dr. Bernstein's Diabetes University, and you'll be able to see a listing for what videos are currently showing. Before we start answering questions, we have some special subjects because there have been major articles in the diabetes journals that are of current interest to my listeners. First, in the December issue of the journal Diabetes Care, which is an ADA journal, there's an article entitled Automated Insulin Delivery Benefits, Challenges, and Recommendations, a consensus report of a joint diabetes study. A number of groups have come up with a report that tells the shortcomings and the benefits of these automatic machines that supposedly control your blood sugars. I've listed them in the past, but this particular article, which you can get in the December 2022 journal Diabetes Care, lists the pros and cons of these automatic blood sugar machines, the ones that have connections to the human body, various connections, and are sensing your blood sugar and pumping in insulin. Another article in the December 2022 issue of Diabetes Care mentions the benefit of finerenone, a non-steroidal mineral corticoid receptor antagonist, for the treatment of more advanced diabetic kidney disease, to slow the usual progression of diabetic kidney disease. It can be used in parallel with other treatments, and this is the first time I've seen mention of finerenone. So if you or someone you know has diabetic kidney disease, you might want to mention it to your physician and he could look into it. finerenone. Now we're again in December of 2022, Diabetes Care. There's yet another article, in this case showing the development of retinopathy in supposed non-diabetics or in very early type 2 diabetes. And this In the past, we've seen articles about retinopathy, articles we've seen about neuropathy, early kidney damage. This is just early retinal damage. The point is that your blood sugar does not have to be sky high to cause the complications of diabetes. The ADA considers an A1C of 6.7 to be normal, yet, as this article shows, diabetic complications, in this particular case retinopathy, is occurring at A1Cs of 6.7. So this reiterates what I've been saying for years, and also parallels my target of 83 that I've been spouting for years. Shooting for 6.7, 6.5, even 6, statistically, given enough time, can lead to diabetic complications. The November 2022 issue of Diabetes Care was a summary of many studies of attempts to control blood sugar over time. And the studies summarized can be called Management of Hyperglycemia in Type 2 Diabetes, a consensus report of the American Diabetes Association and the European Association for the Study of Diabetes. And they're giving over many pages their various recommendations. And one of their conclusions is that lifestyle change is the thing to do. However, at the end of that issue, the December 2022, is an article that looks at the repercussions of their recommendations for lifestyle change. And by lifestyle change, as you could expect, the ADA recommends a high carbohydrate diet with lots of fruit and whole grains and so on. And this article, at the very end of the issue, they put it to the very end, points out that it's no better than usual care, that is, the usual haphazard treatment of the disease. So they go through this long issue, many articles, and at the very end, they let you see that the result of their recommendation is nil. Now we go to the questions for the month. How frequently or what percentage do you see elevated LDL in those with low free T3 hypothyroid disease? I cannot quote percentages because I just haven't collected that data. I have, and most of the reports that you see in the scientific literature I don't think I've seen one study looking at LDL and low T3. What I have seen was low LDL and total cholesterol, which in the articles occurred many years ago during the heyday of the cholesterol myth. So I cannot really answer this question, but we do know that total cholesterol does go up when free T3 is low. I am following your book, and in 3 months I have reduced my A1C to 5.1, but my LDL cholesterol jumped from 103 to 197, so I am concerned. In your book, you stated that your LDL is 53. Why is yours so low and mine so high? I guess it's a good question, and I really don't know the answer. First of all, my book was written in 2011, and I haven't checked my total LDL lately because I look now at LDL, oxidized LDL, at LDL, small dense particles, because total LDL is not a significant predictor of heart disease anymore. We want to look at the pathologic LDLs. So I would suggest that you look at, if you want to look at LDL, that you get tested for small dense LDL and also for oxidized LDL. And that requires other laboratories than the usual laboratories. I was able to get LabCorp to send their specimens to these other laboratories. If you want to measure small dense LDL, you have to get a profile that includes many, many tests and is very costly. And in all likelihood, your insurance won't pay for it because there are so many tests involved, not all of which relate to risk. After 12 years of suffering diabetes, I was finally saved by your Diabetes Solution book. 8 years ago that I have tried to follow so that I now have an A1C of 5.2. Other biochemistries are mostly normal. Having just had CT scans, that's imaging, body imaging, I am now told that I have extensive coronary atherosclerosis, a calcium score of 528, an LAD coronary artery, LAD is left anterior descending coronary artery stenosis. It's partially blocked, 50% blocked. Can you please advise on what kind of treatment I should follow for the coronary artery disease to decrease my risk of a heart attack and heart failure? Well, one thing I would do is check your free T3, your thyroid status. If you have a low free T3, that could be increasing your risk of coronary artery disease. Another thing that your doctor might want to look into was reported recently in the scientific literature. It is possible now to determine whether the plaque in your coronary arteries is inflamed or stable. And if it's stable, it'll sit there in one place and not do any damage. If you have a large-scale stenosis, like one major artery, let's say, has 70, 75%, 80% stenosis, a blood clot coming through there might block it. But the major cause of heart disease from the coronary artery plaque is the plaque actually breaking off and blocking things upstream. And to see if this is stable plaque or inflamed plaque, there's a new, it's actually, I believe, PET scan imaging, which measures what metabolism is going on in the plaque. So that's worth looking into. PET scans are more expensive, but it might be more informative. If you have a cardiologist, he might be very interested in looking into this. "56-year-old type 2. 2 days ago, I was diagnosed with alpha-Cal syndrome. Is there any link or correlation between this and gastroparesis?" I had to look up alpha-Cal syndrome in the on the internet, and any listeners who are interested in it, ALPHA-CAL, you guys can look it up yourselves, and it is not similar to gastroparesis and not related to diabetes or gastroparesis. It's an allergy not a neuropathy. Gastroparesis is a neuropathy. And this is an allergy in particular to the bite of the Lone Star tick. I'm not kidding, this is what it says on the internet. "Doctors can't decide on my official type of diabetes. Does it matter? C-peptide is 0.2, negative for 3 autoantibodies. Disease was diagnosed at onset with diabetic ketoacidosis. After years after I had gestational diabetes, now insulin dependent. I've repeatedly said that what's important is blood sugar, not the name that you give the disease. Diabetes, to me, is a spectrum of diseases that go in different directions. And if you want to be relatively safe from the complications of diabetes, you want to avoid the old standby, which is high blood sugar versus time. In other words, high blood sugars for a long period of time are likely to cause the complications of diabetes. The higher and the longer, the more danger you're in. What you call it doesn't matter. And what you do to treat it really depends on what your blood sugars are. And that's why my book is really a dissertation on trial and error, on experiments. You try a certain treatment and see if it works. So here I have kids who are type 1 diabetics who may be taking drugs that are given to type 2 diabetics and thereby lowering their insulin requirements and improving their blood sugar control. And likewise, I have many type 2 people who are called type 2, their doctors call them type 2, and they are taking insulin. Some of them may be taking only 1 shot of a long-acting insulin a day, and others may be taking a little bit of insulin before each meal. I'm talking about people who've been called type 2. So you do what you have to do to control the blood sugars, and it doesn't matter what you call it. And I'm willing to bet that there are plenty of ADA people who will challenge that. "We found you shortly after my daughter was diagnosed with type 1. She is in honeymoon, and the doctor has taken her off insulin because any amount gives her hypoglycemia. What are your thoughts? Well, it would be interesting to know what your doctor's blood sugars are and how carefully he's treating his own blood sugar situation. I think that we want to keep blood sugars normal. We want to look at blood sugars after meals. We don't want them to go up after meals. It could be that in reality, the blood sugars are really level and in a truly non-diabetic range all the time. That is around 83, which is our target. But in most cases of early type 1 diabetes with a honeymoon period, there are periods of high blood sugars, maybe blood sugars as high as 120. And what we use is diluted insulin. There are only a few insulins that you could dilute, but that makes the insulin much weaker so that you can, let's say you wanted to bring down a blood sugar of 120, you might use regular insulin, and I've used regular insulin diluted 10 to 1, where 1 unit is only an 11th of a unit. And for smaller people, that is for children, you usually need more dilution than for big people. So my thoughts are that you look at the blood sugars, you know that normal is clustering around 83, and for kids, normal can be, depending how young they are, normal can be 65 or 70 or 75. So you can also dilute NPH insulin, which is an intermediate acting insulin. It doesn't last 24 hours. So if you need a longer acting insulin, you might have to take diluted NPH 3 or 4 times a day. And this sort of thing, I believe, is discussed in my book. I remember many years ago, I was treating a kid who was, I think, 1.5 years old, and I taught his family care doctor to treat his diabetes, and we used diluted NPH many times a day, plus diluted regular for meals. And I understand he's now in his 20s, still having normal blood sugars and in very good health. So it pays to preserve the honeymoon period when the kid is still making insulin. It makes it much easier to treat the disease when he gets older. And I do have a patient that I started treating in 1985, and she's getting, and she ended up with half the dose of insulin. She was an adult. She ended up getting half the dose of insulin that someone her size would ordinarily make. And she's still getting that same dose, and it's many years later. I guess it's almost 40 years later. We preserved her honeymoon period. My 10-year-old, 41 kilogram, has an A1C of 6.9, which is an average blood sugar of about close to 180, let's say 170. Was diagnosed with type 1 diabetes a year ago. How do I better calculate his carbohydrate coefficient? Well, I guess that what this parent is calling a diabetes, a carbohydrate coefficient, is how much uh, carbohydrate will be covered by 1 unit or a half a unit of insulin or a tenth of a unit of insulin. And this is a real trial and error game, and probably requires experimenting with diluted regular insulin. And one thing that you could do is adjust the long-acting insulin dose so that he or she is level overnight. And then when she wakes up in the morning, you you can give a relatively rapid acting carbohydrate that you measure, like maybe a glucose tablet, for example, and you see how high the blood sugar goes up, and you guess at an amount of regular insulin diluted, and you're going to have to guess at the dilution, and you give it intramuscularly. And in the book we show how to give an intramuscular injection, so you have to read my book to do any of this stuff. And you give it, let's say, 7 hours, and see how much the blood sugar came down over that 7-hour period. And maybe it came down too low. Maybe it came down halfway to a target of, let's say, 80. Using that information and repeating the experiment on different days, you can eventually come to a number that makes sense for your child. It's not easy, and that's why we do trial and error experiments. My A1C is 10%. Now I have to figure out what the average blood sugar is. It's around 300 milligrams per deciliter. So it looks like statins did their job and significantly lowered my LDL. So this person is taking statins, and I guess he realizes that statins can raise blood sugar. I wonder if following your diabetes protocol, there's a chance I could also lower my LP small a. Great. I suggest this person read my book. LP small a, as it turns out, in my experience, is the most potent of the risk factors that you could measure in the blood. The reason I say that is that the few people who came to me as new patients already having an elevated LP small a had already had heart attacks, and then at relatively low ages. So in my small experience with elevations of LP small a, which is relatively rare, it looks like a very potent predictor. And I have not seen evidence that normalizing blood sugar has an effect on LP small a. The usual thing that you see is a woman who is estrogen deficient. And there, when you replace her missing estrogen, the LP small a plummets. And I've gotten that down to normal in several women just with estrogen replacement. And a typical scenario is one that I'll never forget. This lady was 50 years old and had a heart attack a major heart attack before she saw me. She had been a ballroom dancer, and she and her husband would dance every night for years. So she got plenty of exercise. She had a total hysterectomy for cancer at age 30, and and her ovaries were removed, so she had no estrogen, and her doctor did not put her on estrogen replacement. So here, for 20 years, she was deprived of estrogen, and her LP small a was 175, sky high. I think normal is, depends on the lab you use. Some labs it's up to 15, and other labs it's up to 75, but she was 175. And we gave her estrogen, and her LP small a came down. We couldn't undo the heart attack. And I had one man with an LP small a that was elevated, and his probably was hereditary because he came from a family where men had heart attacks. We don't know what their blood chemistries were, but they had heart attacks at relatively young ages, and it could well be that they all had elevated LP small a's as he did. So that's about the information I can give you. One other bit of information is if your blood is drawn to measure LP small a and the blood is frozen, it will destroy the LP small a. So you cannot, it's inappropriate to measure LP small a on frozen blood. My A1C has been between 4.4% and 4.8%, thanks to your book and videos. However, my doctor noticed that my uric acid is between 7 and 8%. Now, right off the bat, that's sort of meaningless to me because when I see a blood screen, a chem screen, the uric acid, when it's done, is usually reported in milligrams per deciliter or millimoles per liter, and I'm not used to seeing percentage used. If I increase the amount of carbohydrates from 30 grams to 50 grams a day, my uric acid is in the normal range of 5.5%. I bought a uric acid meter to check the value every day. It is definitely due to the amount of carbohydrates. Now, would you accept high uric acid levels for better blood sugar control, or increase carbohydrate to 50 grams per day and have higher blood sugars but better uric acid levels? Well, my guess is that it's not the higher carbohydrate that's lowering the uric acid. My guess is that you're eating less meat, less red meat, on the days that you have more carbohydrate. And when you've cut the carbohydrate, you're probably satisfying your increased hunger by eating red meat, which does increase uric acid. There are some oddball beans that also will raise uric acid. But my guess is that if you reduce the red meat, switch to fish or seafood, that the uric acid will come down. It also would be interesting to know why your doctor is testing uric acid, whether he's testing urine or blood, and whether you have gout. That's usually it's usually gout that worries the doctors about uric acid. Whenever I play in a soccer game, my blood sugar goes really high, and I have followed your book for 3 years. I have a flat CGM graph, that's continuous glucose monitor, when not playing soccer. I just got prescription for propranolol. I haven't tried it in a game yet, but tried for solo practice yesterday, and it took all my strength away. Can you recommend something besides propranolol? Well, those of you who have been long-time listeners know that I frequently recommend propranolol for people who have who produce a lot of adrenaline or epinephrine when they get excited. Musicians when they perform, teachers when they teach, opera singers, and kids when they play a competitive sport, when they play it against another school, their blood sugars go up. So this anxiety tends to raise blood sugar. And propranolol blocks the effect of adrenaline so that the blood sugars usually don't go up if it's working. Now, propranolol can slow a lot of things by blocking epinephrine, can slow the heart rate and can slow other functions of the body that are stimulated by epinephrine. And it could be that this person is taking too high a dose. Usually with kids, I start with a 5 milligram dose. And some of them, the bigger kids may need to go up to 10 milligrams. With adults, I usually start with 10 milligrams, and I have one big guy, muscular guy, who sometimes takes 20 milligrams. That's the most a patient of mine has ever used. I don't know what dose this person is using, but it could be that he's getting too high a dose. So that's the only thing I could think of. If a small dose is making him weak, then it's not the answer. So my guess is that you're taking a big dose and that you should lower it. Let us know what happens. Send us an email at diabetesuniversityquestions@gmail.com. Is there any relation between flat feet and diabetes? Do you recommend treatment for this condition? It reminds me of my childhood. I was overweight. I looked fat when I was 8 years old, starting when I was 8 years old, and remained overweight until I developed diabetes and lost 20% of my body weight. Our gym instructor, his name was Sid King, was a very smart guy. He gave us lectures on personal health, and he looked at this fat little kid, me, and he said, "Do you have flat feet?" And indeed, I did. And later, when I was a bit older, the flat feet started causing plantar warts. And a smart doctor of mine prescribed orthotics. And that's what I'm recommending for this person. And I have my original orthotics. Just a minute. This is the orthotic that my doctor prescribed for me when I was a teenager. I was about 15. And I still wear orthotics, but I use these over-the-counter ones that are a lot less costly than these were. I even remember where I had these custom stainless steel orthotics made. They were made by a guy named V.C. Maurizio on Lexington Avenue and 106th Street in Manhattan, New York. And both the stainless steel ones and the plastic ones worked very well. And I heartily recommend orthotics for your flat feet. And it will be necessary over time to prevent you from developing new problems with your feet. In your videos, you recommend 2 glucose meters, the Freestyle Freedom Light and the Contour Next. I bought both, and I discovered that the Contour always differs by around 10 milligrams. It's around 10 milligrams per deciliter higher than the Freestyle. Which one should I believe? Well, my preference in the normal range is the Freestyle. Since for myself, I try to keep blood sugars close to 83. The Freestyle is more accurate in that range. Now, there have been large-scale studies done by other people, and they've found that at the high blood sugars, which the patients usually experienced in the studies that were not mine, the Contour was more accurate. So if you're going to shoot for high blood sugars, use the Contour, and if you're going to shoot for normal blood sugars, use the Freestyle. You have to take a break here. What do you think about the following treatments for type 1 diabetes? High doses of vitamin D3. Studies have actually been made because it's been found that type 2 diabetics tend to have low levels of vitamin D3 in their blood, but giving replacement of the D3 to the type 2s hasn't improved their blood sugars. So I doubt that it's going to help type 1s. But I do recommend that everyone in the northern part of the country, of the USA or any part of the world, northern part of the world, take supplemental vitamin D to bring your blood level into the normal range. BCG vaccine to modify the immune system and reduce blood sugar levels. There have been studies going on BCG vaccine, which is a vaccine that's usually given to immunize people against tuberculosis. And some labs have claimed cures for diabetes. Some labs have claimed that we prevent the onset of diabetes for people who are susceptible to it. But when others try to duplicate these results, they've been unable to duplicate the results. So these studies have been going on and repeated for the past at least 20 years, maybe longer. And thus far, nothing has come of this. I can't say nothing will come of it, but thus far nothing useful has come of it. Inject stem cells into patients. Likewise, there are problems with that that will stop. The stem cells can't just be injected. First of all, you inject foreign stem cells, whether from another person or from an animal, the immune system is going to reject them. So studies with stem cells are done with people who are getting kidney replacements and are put on immunosuppression therapy. And immunosuppression is a very difficult thing for a patient to handle because they're subject to all kinds of diseases, especially COVID. So it's a big risk to submit to immunosuppression. And in theory, we know what human stem cells are. We know that the cells that line the ducts of the pancreas are stem cells for beta cells. We also know that the alpha cells that make glucagon are stem cells and can be transformed to beta cells. So in theory, you might operate on a diabetic, scrape out some of his stem cells, grow them in a culture medium at tremendous cost, and wait months while they're growing. And then where do you inject them? You have to inject them back in the pancreas where they're in a milieu that fosters their survival. Injecting in the liver, you'll get temporary survival, whereas injecting into the pancreas with the blood supply that's found in the pancreas, much more likelihood of survival. So this is very tricky business, very hard to do, very expensive, and it just ain't ready now. There are labs that have claimed success, and when you look at the A1Cs of these so-called successes, the A1Cs aren't normal. They're ADA normal, maybe, for a short period of time. Information has been coming out saying there could be benefits for type 1 diabetes to take metformin. What are your thoughts on this? I've been using metformin for type 1 diabetes for a long time, usually on pubescent kids, because as they go into puberty, they become insulin resistant, and we have to give them high doses of insulin. Becomes tougher to control their blood sugars, and I found that metformin makes it easier. Now, it doesn't always work. Sometimes you have to wait a little longer before you give it to them, but most of the kids that I've treated who have gone through puberty have gotten metformin and have done much better with the metformin. There are problems giving anyone metformin in that some people develop digestive problems, diarrhea, constipation, and so on. There are tricks to using it that I think I discuss in my book, Diabetes Solution, but I also discuss these tricks in my videos. So there probably are a number of videos out there that give you tips on how to introduce metformin. And it's not for everyone, because not everyone can tolerate these side effects. Um, and the side effects are not universal. Are there other impacts, often having blood sugar stay in the 60s for hours of time? Oh, this person is asking, if his blood sugars are in the 60s for hours, does it do any harm? And I don't think it's a good idea. For kids, there are studies that show that young children may normally have blood sugars in the 60s. And pregnant women at certain times during pregnancy may have blood sugars normally in the 60s. It's possible that being in the 60s for days on end might lower your ability to detect hypoglycemia. It might also lower your ability to produce glucagon and epinephrine in response to hypoglycemia. So I don't think it's a good idea, but I don't have hard evidence. There may be some studies out there in the scientific literature that you could search for. So hypoglycemia unawareness is a likely outcome. My youngest child is 14 and was diagnosed with type 1 a year ago. We recently discovered the Bernstein way of eating and have started it. Do you believe we can preserve enough beta cells to continue the trend of not needing long-acting insulin or even short-acting? How long have you seen the honeymoon period last? Also, do you still see patients in your practice? Or does the, in order to book, how do we book an appointment with you? You can book an appointment by dialing 914-705-9933, and you can speak to the person who books new patients. 914-705-9933. Most people are able to take care of themselves via the book. Now, the question about just changing the eating to preserve beta cells. You need to have normal blood sugars. And that takes more than just eating the right diet. It means probably taking diluted insulin, as I've mentioned earlier. And it's tricky business. It's not easy to do. And this can be a valid reason for making an appointment with me. I already discussed the manipulations that you have to go through in order to figure out how much insulin to take and when. It's tough business, but to just think that the diet alone is going to do the trick, very unlikely. What do you think about the vegan fruit eating, type 1 diabetes, who complain that animal fats, not carbs, is the culprit for type 1. And that's okay to eat lots of fruit, mangoes in particular. Well, right away, it reminds me of a little song about mangoes. Underneath the mango tree, me honey and me can't wait for the moon. Underneath the mango tree, me honey and me make bulaloop soon. I don't think that that's an answer to treating diabetes. I think that any diabetic who eats fruit is going to have high blood sugars and uncontrollable blood sugars, maybe trying to chase the blood sugar swings with insulin and then going too low. So tain't the thing to do, and it's not going to work. And the cause of diabetes is not high fats. My daughter is a type 1 diabetic with an A1C of 7%. That's an average blood sugar of probably around 170 milligrams per deciliter. We are trying very hard to apply a low-carb diet, but we have many troubles. She's always hungry. Well, one answer to that is to increase her dietary protein. You can't be starving her, and growing kids need more protein than per kilogram of body weight than do adults. So all of the kids I'm treating are getting substantial amounts of protein in their diet. And the protein can be of many kinds. It can be red meat, can be fish, can be seafood, can be cheese. Yogurt has some protein, but it also has a lot of carbohydrates, so a lot of yogurt is not an answer. But a lot of my kids like cheese. A lot of them like seafood, so that helps. She spikes from 70 to 350 as soon as she sleeps at night, almost most nights. Is there anything to prevent this? Again, you should read my book, and there are treatments using long-acting insulin. But the book is a must. Diabetes Solution. Thanks for watching Dr. Bernstein's Diabetes University. Happy New Year, and take care of yourselves and someone else if you get the opportunity. Thank you.